Hello, my friends. Let's start with our topic for today. Today, our topic of discussion is hyponatremia, meaning to say less sodium in our body. In medical term, hyponatremia is defined as a decrease in serum sodium concentration below 135 milliequivalents per liter. Normal serum sodium level is between 135 to 145 milliequivalents per liter. Hyponatremia can be divided into various severity groups by the level of serum sodium in our body. It could be mild. The sodium level will be 130 to 134 milliequivalents per liter, or moderate serum sodium will be 125 to 129 milliequivalents per liter. Severe, the level will be below 125, and very severe, where the serum sodium value would be even less than 120. The basic concept to understand serum sodium is equivalent to total body sodium divided by total body water. Any condition which increases total body water, or any condition which decreases total body sodium, eventually leads to hyponatremia. Another important concept to understand that to diagnose and treat hyponatremia, we need to measure plasma osmolarity. Plasma osmolarity is the concentration of all osmotically active particles present in 1 liter of plasma. It reflects how concentrated or dilute the blood is. Main substances contributory to plasma osmolarity are sodium, which will be calculated in milliequivalents per liter, glucose and blood urea nitrogen. This too will be calculated in milligrams per deciliter. Common formula to measure plasma osmolarity is plasma osmolarity equals to 2 into serum sodium value plus blood glucose level divided by 18 plus blood urea nitrogen divided by 2.8. Now, you might be thinking why we need plasma osmolarity and all this calculations, but believe me, it all will make sense in our next upcoming slides. The classification of hyponatremia can be based on measured serum osmolarity, where if serum osmolarity is less than 280 milliosmoles per kilogram, it will be called hypertonic hyponatremia, also called true hyponatremia. If the serum osmolarity is between normal range, which is between 280 to 295 milliosmoles per kilogram, it is isotonic hyponatremia. Or, if the serum osmolarity is greater than 295 milliosmoles per kilogram, it is hypertonic hyponatremia. Hyponatremia can be classified based on the time of development also. If it happens in less than 48 hours, it is classified as acute hyponatremia. And if it gradually happens in more than 48 hours, then it is classified as chronic hyponatremia. Acute hyponatremia causes water to move into brain cells, leading to edema. Symptoms depend on the severity and speed of sodium fall. Mild to moderate symptoms are nausea, vomiting, headache, dizziness, generalized weakness, confusion. Severe symptoms are altered mental status, agitation, seizures, coma, even respiratory arrest due to brainstem herniating. Symptoms of chronic hyponatremia are often milder and more subtle than acute hyponatremia because brain adapts over time. Common symptoms include fatigue or low energy, nausea, headache, poor concentration, memory problems, unsteady gaits. But the most important classification of hyponatremia, as far as the exam-oriented questions are concerned, is based on volume status. Based on the volume status, hyponatremia can be classified in 3 groups. Number 1 is hypovolemic hyponatremia, number 2 is euvolemic hyponatremia, and number 3 is hypovolemic hyponatremia. In case of hypovolemic hyponatremia, the total body water and the total body sodium both would be reduced, but the total body sodium decreases more in proportion of total body water. As the patient will be in hypovolemic state, there will be certain clinical signs, like dry mucosa, tachycardia, hypertension, poor skin turgor, orthostatic fall. The causes of hyponatremia can be extrarenal causes, or renal causes. To differentiate this, we usually have to measure the urine sodium. If the urine sodium value is less than 20 milliequivalents per liter, it's considered as extrarenal cause of hypovolemic hyponatremia. Most common extrarenal causes are gastrointestinal causes like vomiting, diarrhea, nasogastric suction, pancreatitis. Other extrarenal causes are excessive sweating, burns, third space fluid losses like peritonitis, ascites, severe trauma, sepsis. And if it is more than 20 to 30 milliequivalents per liter, it's considered as renal cause. Here, kidney lose too much sodium and water, with sodium loss predominating. Most common renal cause of hypovolemic hyponatremia is use of diuretics, especially thiazides. Other causes are Addison disease, hyperaldosteronism, cerebral salt-wasting syndrome, etc. Hypovolemic hyponatremia is a condition where serum sodium concentration is low, less than 135 milliequivalents per liter, but the total body water is increased slightly. While total body sodium remains normal, so the patient appears clinically normal in volume status, neither dehydrated nor fluid overloaded. The most common cause of euvolemic hyponatremia is syndrome of inappropriate antidiuretic hormone secretion, in short SIADH. In this condition, there is excess antidiuretic hormone, which acts on V2 receptors in collecting ducts of kidney, inserts aquaporin to water channels, which causes more water reabsorption. Because of this, serum sodium becomes diluted and causes hyponatremia. But here the question is, if there is increase in total body water, then why the status is euvolemic? Actually, the expanded extracellular fluid volume suppresses the RAAS system and increases natriuresis. Due to this, renin and aldosterone is reduced, and sodium excretion alongside water from kidney increases, which keeps the body in euvolemic state. Other causes of euvolemic hyponatremia are hypothyroidism, Addison's disease, primary polydipsia, beopotomania. Now let's know about the hypovolemic hyponatremia in brief. In case of hypovolemic hyponatremia, there is low serum sodium, less than 135 milliequivalents per liter, with increased total body water. Water gain is proportionally greater than sodium gain, eventually causes dilutional hyponatremia. In the conditions like liver cirrhosis, congestive heart failure, chronic kidney disease, nephrotic syndrome, protein-losing enteropathy, the extracellular fluid increases, which causes edema, but the circulatory fluid volume decreases, which activate the renin-angiotensin-aldosterone system, which causes sodium and water retention. Because of less circulatory volume, plasma osmolarity increases, which triggers more antidiuretic hormone release from posterior pituitary gland, and more water reabsorption happens in kidney. Triggers the dilutional hyponatremia. Now we will move on to the treatment of hyponatremia. Treatment of hyponatremia can be quite tricky in many cases, so we need to have proper knowledge to treat hyponatremia, and it differs from patient to patient. Early diagnosis and appropriate treatment reduce morbidity and mortality. There is no fixed treatment protocol for patient with hyponatremia. For acute symptomatic hyponatremia, the management will be based on the severity. Here, 3% NaCl is preferred, which contains 513 milliequivalents of sodium per liter. The conventional formula for sodium correction is sodium requirement equals desired sodium minus actual sodium times total body water, where total body water equals 0.6 times total body weight for adult male and 0.5 times total body weight for female. The calculated sodium deficit should be corrected over 24 hours, and the correction should be gradual. Correction of hyponatremia should not be more than 8 to 10 milliequivalents per liter over 24 hours, because acute correction can cause osmotic demyelination syndrome, which is a stroke-like manifestation, quadriplegia with positive Babinski sign. Let's understand this formula with a clinical example. The clinical scenario is a 60-kilogram female athlete, marathon runner, collapsed before finishing the race. On admission, her lab reports show serum sodium of 120 milliequivalents per liter. Here we can see the patient has severe hyponatremia and we need to correct it. Let's put the values in our formula to get the patient's sodium deficit, which we need to correct over 24 hours. Sodium deficit equals desired sodium, which is 128, because we will not rise the serum sodium very acutely because of osmotic demyelination syndrome, minus the actual sodium, which is 120 milliequivalents per liter, times total body water. As we know, total body water equals to total body weight times 0.5 for females, means here 60 times 0.5. So the total sodium deficit is 240 milliequivalents, meaning to say if we want to increase the serum sodium from 120 milliequivalents per liter to 128 milliequivalents per liter, we have to give 240 milliequivalents of sodium to this patient over 24 hours to avoid other complication of acute correction of hyponatremia. So now if we use 3% NaCl for this case, we have to calculate what will be our infusion rate, right? As we know, 1 liter of 3% NaCl contains 513 milliequivalents of sodium, but we need only 240 milliequivalents over 24 hours. Means if we infuse 19.5 milliliters of 3%, proper treatment is necessary for even asymptomatic chronic hyponatremia. We will get our due to its potential to cause attention deficits, gait disturbances, and increase risk of falls and fractures. Chronic hyponatremia should correct gradually. Rapid correction carries risk of osmotic demyelination syndrome. Treatment of chronic hyponatremia also should be based on volume status. In case of hypovolemic hyponatremia, patients requires fluid and salt supplements to correct serum sodium and simultaneously restore intravascular volume. The administration of 0.9% normal saline or balanced crystalloid solution at 0.5 to 1.0 milliliters per kilogram hour effectively corrects hypovolemic hyponatremia. In most cases, restrict intake of simple water and low sodium containing oral or intravenous fluids like dextrose solution, 0.45% NaCl, all isolite solution, because it may aggravate hyponatremia. Diuretics-induced hyponatremia is treated by discontinuing diuretics therapy with combination of salt supplementation and potassium to restore deficit. For the treatment of hypovolemic hyponatremia, the treatment approach will be different. As hypovolemic hyponatremia seen is patient with congestive heart failure, liver cirrhosis, chronic kidney disease, the supplementation of sodium may worsen fluid overload. It is challenging to treat hyponatremia in patients with edema. The supplementation of salt carries the risk of fluid overload, therefore generally avoided. The mainstays of therapy are salt restriction and fluid restriction. Loop diuretics are first-line therapy that helps to excrete free water in hypovolemic hyponatremia, reduces edema, and corrects hyponatremia. The addition of potassium-sparing diuretics like spironolactone is helpful for preventing diuretic-induced hypokalemia and reduces edema in congestive heart failure and cirrhosis. The second line of therapy is vasopressin antagonist like Vaptans. In hyponatremia, patient with renal failure, oliguria, and volume overload who are not responding to medical management. Offering hemodialysis is an effective option. In case of euvolemic hyponatremia, the most common cause is syndrome of inappropriate antidiuretic hormone secretion, in short SIADH. We discuss the pathophysiology of SIADH briefly in this video prior to. The standard first-line therapy is water restriction alongside treatment of underlying ethology. If there is acute symptomatic hyponatremia, the mainstays of treatment are water restriction, hypertonic saline, furosemide, avoid hypertonic fluids. For the chronic asymptomatic patients, the treatment action will be water restriction, high salt, furosemide, high protein diet, Vaptans, democlocycline. Rate of rise of sodium should be 8 to 10 milliequivalents per day. I hope this video will help you all for your exam purpose and better understanding of the topic. Please do not forget to like, comment, and subscribe.